Can I see Sidra? Yeah. Sidra is here. Okay, so let's start the meeting. Welcome to the International Conference on Children and Their Families using the mixed dataset. My name is Deepak Kumar. I am the Regional Mix Coordinator for UNICEF Regional Office for Europe and Central Asia. I will be chairing today's online session titled Health Seeking Behavior, Curative Care. My co-chair today is Beshanski-Pedersen. He is the survey expert in Mix headquarter team. Before I introduce our speakers, a few words of housekeeping. The session will be recorded and hosted on the UNICEF Mix website and the YouTube channel, as well as on the Bristol Poverty Institute YouTube channel. By attending this session, you consent to be part of this recording. Please ensure that you have added your name rather than being listed as guest. I can see all the names here, so no worries on that. After the presentations, at the end, we are going to have a Q&A session, which will be taken care by Bo as a co-chair. You can see the Q&A function on the top of your screen. Please note that the chat function is not available to attendees, so please use Q&A function. Please be respectful. All events at the conference are being monitored, and we reserve the right to remove attendees whose comments are deemed offensive. So let me quickly introduce the presenters. We are going to have three presentations today in this session. Each presentation is going to be 20 minutes. The first presentation will be from Dr. Murendo. He is from Save the Children, placed in Afghanistan. The second presentation will be from Maryam, and the third presentation is from Zone Tingkai. So let me first call for the presentation, Ms. Dr. Murendo. Murendo, floor is yours.
Thank you, Deepak, and let me load my presentation.
Perfect. You can go for slideshow. Yeah.
Confirm you can see my presentation.
Yeah, I can see your presentation, and you are loud and clear. Over to you.
Okay, thank you so much. I'm Conrad Murendo. I'm the research manager with Save the Children, based in Afghanistan, in Kabul. So I'm going to share with you results on the inequalities in women healthcare seeking behaviors for under 5 children illness in Afghanistan, which draws data from the 2022 Afghanistan Multiple Indicator Cluster Survey. We know from literature that access to health care for under 5 children reduces morbidity and mortality. However, there are a few studies that have systematically analyzed healthcare seeking behaviors in Afghanistan, with the exception of Tafik. More so, there's lack of studies that have looked at the wealth-related inequalities with regards to health-seeking behaviors for under 5 children illness and its determinants. And we know that this is important for policy making, especially in programming, especially for us in the programming side. This is important for having inclusive health interventions that look at both the rich and the poor, women and their respective children, and also interventions that are there to eliminate child illnesses are very important, especially for our under 5 children, given that this is the period that they are growing. And also, if we miss this, then that will affect their developmental outcomes. With this, the objective of this study is to analyze the inequalities in women healthcare seeking behaviors for under 5 children in Afghanistan, and in particular, using the 2022 dataset post the change of authorities. The methodology that we use is the multiple indicator cluster survey for 2022, where we use the data from 34 provinces. We use the data from children under 5 questionnaire that was administered to about 33,000 mothers or caregivers. In terms of measurement, how we measured the outcome variable is basically women respondents who sought healthcare services for under 5 children, fever, cough, and diarrhea at any health facility in the past 2 weeks. So anyone who experienced this was coded as 1 and 0 otherwise. For the wealth indicator, that is our socioeconomic indicator, we use the principal component analysis to compute an index which included the possession of durable goods, household assets, and characteristics. And these were then collapsed into quintiles from the poorest to the richest. For the independent variables, we also then controlled for the sex and age of the child, whether the child is underweight, the number of under 5 children in the family, and also health-seeking behavior is also a function of health literacy. So we included mother's education, paternal education, internet, and also the spatial location of where the women reside. In terms of analysis or estimation strategy, the inequalities in women healthcare seeking behavior for under 5 children illnesses were investigated using the concentration index and the curve. The concentration index is primarily a function of the covariance between the health-seeking behavior and the fractional wealth distribution, and this is divided by the variable mean. This has been used extensively by Elgas and other authors, but because our outcome variable is binary, the health-seeking behavior for women, we then use the Elgas corrected concentration index. This basically then accounts for the binary nature of the outcome variables. We also then visualize this, the concentration curve, which is basically we are comparing the line of equality, which is a 45-degree line on our graph, and the concentration curve. If the concentration curve for health-seeking behavior is on the right side of the line of equality, then it means the inequality is favoring the richer women. Then if it's on the left side of the line of equality, it's a poor situation where our inequalities are favoring those who are in the poor category. In terms of finding the contribution of the selected factors or variables to the inequality, we use what we call the Elgas decomposition technique, which then helps to identify and quantify the inequality for this binary outcome variable. Then moving on to the results, we start with the descriptive results, where we diagrammatically put the health-seeking behavior and the wealth quintiles. So from the far left, we have the poorest quintile, where about 33% of women or caregivers sought health care for their children illnesses. Then as you move to the far right, it slightly increases to 41% in the richest category, which shows that there's need for, I think, mechanisms to nudge poor people to seek healthcare services. And also, intuitively, we can say there's need for health literacy so that we can also then increase supplies of healthcare facilities. But in the next section, we are going to explain much on the empirical results, as these are just descriptive results. So in terms of our empirical results, we start looking at the concentration index, which is 0.040, is positive and significant. So what it means is the health-seeking behavior for under 5 children illnesses among women is concentrated among women from richer households. And this is disfavoring women from poorer backgrounds. When you look at the concentration curve again, here the line of equality is in red. Then our healthcare seeking concentration line is below the line of equality, and it shows that again we have pro-rich inequalities, and all the interventions, I think now for healthcare interventions, they need also to look at inclusivity so that we can also include the poorer women, right? In terms of the decomposition now, we look at the ERGAS decomposition analysis, where it computes the elasticity absolute contribution and the percentage contribution. We primarily look at the percentage contribution column. What this means is for wealth and the rural residents, they explain 38% and 36% of the total inequality in health-seeking behavior for children illnesses. So any interventions that improve wealth among the households tend then to remove the inequalities, and also residing in the rural residents explains a lot of inequalities. So maybe we need interventions that improve equitable wealth income generation so that we can reduce health inequalities. Also, given that rural residents explain a larger proportion of the total inequalities, we need to look at healthcare-related challenges in rural areas with a view of reducing the inequalities. This can look at areas which address transportation distances to the health facilities, looking at the availability of medicines within the health facilities in rural areas, access to knowledge on health so that our poor women or participants in Afghanistan can have adequate knowledge around healthcare. They can seek healthcare timely, they can arrive at the health facilities timely, and they can access adequate medication, which in theory they call it the 3 delays approach. So overall, our results show that there's need for tailored healthcare interventions to women from poor households because they are disadvantaged, and we need to understand that increase equitable household wealth, and also there should be intentional efforts to target women from poorer households with income generating activities in the spaces where they are allowed to work around women entrepreneurship, women agribusiness, and resilience building projects. Also decentralizing health facilities in rural areas and stocking them with medicine as poorer people reside in rural areas. And when we put all these health facilities and medication nearer to their doorsteps, that will also be a plus. Promotion of health awareness and education, looking at health literacy, especially in rural areas, should be enhanced and upscaled. And all these efforts will end up improving healthcare access for both women and children in Afghanistan and reducing the health-related inequalities. In terms of additional analysis, I'm now looking at the spatial analysis where I'm computing the concentration index for each province to account for spatial differences, and also looking at the possibility of including additional variables as a robustness check. Additionally, also expanding this not merely from Afghanistan, but looking at other countries from Asia, for example, Myanmar, Nepal, Pakistan, doing similar analysis, multi-country analysis, to see whether these results hold that wealth has an implication on health-seeking behavior. So this is some ongoing work that I'm currently doing. And basically the references, and with this, thank you for your attention and for your listening. I hand it over to Deepak.
Thank you very much, Dr. Murendo. This is a very insightful presentation. We have still 4 minutes for the next presentation. In case attendees, if you want to write or post your questions, you can use this time. In the meantime, I wanted to call and introduce our second presenter. The second presentation is on multidimensional energy poverty and respiratory health in young children. 2 presenters are there, Maryam Sadiq and Sidra Younas. Both the presenters are from the Department of Statistics from University of Azad, J&K, Pakistan. Maryam, take the floor so that you can upload in the meantime and then take the opportunity of extra 2 minutes. Maryam? Can you hear Maryam? Madam Sidra, can you hear me? Bo, can you hear me?
Yes, loud and clear. If supposedly if people have trouble connecting or able to speak,
hello,
please. Yes, perfect.
Can you hear me?
Yes.
Yes, Maryam, we can hear you.
Okay.
May I request
Hello,
you
how are
to
you?
upload? Very good. Maryam, may I request you to upload your presentation?
Okay.
I already introduced you and the co-presenter to the audience. You need to upload your presentation.
Yeah, I'm opening my presentation.
And then you can share your screen. Perfect.
Can you see my presentation?
It's coming. Perfect. It's there. The floor is yours, Maryam.
Okay. Thank you so much. Right. And ladies and gentlemen, thank you so much for being here today. And before start, we would like to thank the reviewers for our nomination. Also, we are thankful to the conference organizing committee. So my name is Maryam Sadiq, and I am an assistant professor in the University of Azad, Jammu and Kashmir, Muzaffarabad, Pakistan. We are very happy to be here in front of you, and we are going to present the research titled Multidimensional Energy Poverty and Respiratory Health in Young Children, and empirical evidence from 26 energy poor countries. Energy is central to addressing many of today's global development challenges, including poverty, inequality, climate change, food security, health, and education. The link between energy and the Sustainable Development Goals, abbreviated as SDG, have been discussed extensively in the literature. In fact, if current trends continue, more people will be without modern energy access in 2030 than currently. Improvements in energy intensity are not in line with SDG targets. The average annual rate of improvement in global primary energy intensity between 2015 and 2020 was 1.4%, which is still behind the SDG target 7.3 of 3.4%, as 675 million people don't have access to electricity, and sub-Saharan Africa is home of 4 in 5 of them. Energy poverty has been associated with a diverse range of adverse health impacts, including respiratory disease in children, and hence reduced energy poverty is a key factor to achieve SDG 3 of good health and well-being. Poor developing countries rely heavily on traditional biomass, including wood, coal, charcoal, sawdust, wood chips, garbage and plastic, crop residual, shrubs, animal dung, and kerosene or paraffin oil for their basic energy needs. On the other hand, energy efficiency is defined as ensuring access to affordable, reliable, sustainable, and modern energy for all. According to SDG, energy security includes use of electricity, liquefied petroleum gas, natural gas, and biogas for cooking, heat, having ownership of household, educational, and telecommunication appliances. According to World Health Organization, acute respiratory infections, or ARI, are responsible for almost 20% of all deaths in children aged less than 5 years worldwide, which is significantly associated with indoor air pollution attributed to solid fuel use, with the highest burden occurring in low and lower middle income countries. According to literature, ARI is also associated with socio-economic status of family, area of residence, and income level of country. So the main objective of this study is to propose an extended multi-dimensional energy poverty index by using related variables measured by multiple indicator cluster survey. Then this index is used to determine the association between energy poverty and acute respiratory infections in young children of low and lower middle income countries. This study also focuses on identifying the effect of area of residence, wealth index of family, and income level of country on ARI in young children. For this study, the data of 11 low-income countries and 15 lower middle-income countries is obtained from multiple indicator cluster survey program with a total of 3,40,703 observations, which is collected during 2017 to 2023. For visual display of descriptive statistics, bar plot and pie charts are used to study the basic characteristics of the population. Then the correspondence analysis is executed as a test of association between variables. And finally, the partial least square is applied as a classification method in the presence of correlation. Table 1 shows the extended multidimensional energy poverty index, MEPI, displaying the dimensions and weightage of different indicators, including cooking, lighting, household appliances, entertainment or education, and communication, highlighting the proposed modifications. Indoor pollution is included as a new indicator of lighting. Availability of washing machine, dryer, and air cooler fan are introduced as new variable of household appliances. Availability of computer and access to internet are proposed variables in the dimension of entertainment or education. Then table 2 presents the variables and indicators of acute respiratory infections defined by World Health Organization and UNICEF. The definition of ARI is based on mother's perceptions of a child who has a cough, fever, and is breathing faster than usual with short and quick breaths. Then the results section displays the distribution of the observations across region, showing that the maximum respondents belong to sub-Saharan Africa, following the samples from South Asia. Then the distribution of the observations across countries is examined, and it is observed that Pakistan has maximum contribution in this data set. Next, we will display shows the distribution of the observations across income level of countries, showing nearly 66% samples are resident of lower middle income countries and remaining 34 belongs to low income countries. Then the observations are distributed according to wealth index of household. And it is observed that poorest and poor families contributed nearly 33% and 26% samples respectively. And only 6.7% richest families are involved in gathering this data set. Then the figure showed the distribution of the observations according to multidimensional energy level of household. The graph evidenced that 44.7% households are energy poor and 55.3% households are energy excess for the observed data. Then the biplot from correspondence analysis is constructed between energy source and region of residence to examine the correlation between them. The plot shows that charcoal, wood, coal are frequently used in sub-Saharan Africa as an energy source. The South Asian residents avail biogas stove, crop residual, straw, shrubs, gas, animal dung, sawdust, wood chips, and alcohol as energy source. The energy excess of liquefied petroleum gas and solar cooker available to inhabitants of Middle East and North Africa. The East Asia and Pacific region has kerosene or paraffin oil available as energy source. The residents of Latin America and the Caribbean used gasoline or diesel. Then the next bioplot shows the results of correspondence analysis for energy source and family income. It is observed that the poorest and poor families used crop residual, grass, shrubs, straws, animal dung, or waste, wood as energy source. Middle income families have access to garbage or plastic and wood chips, while biogas stove, coal, solar cooker, kerosene or paraffin are the sources available for rich families. And according to the observed data, rich families used electric stove, piped natural gas stove, liquefied petroleum gas stove as the energy source. Then partially square is used as a classification technique to examine the effect of energy poverty, wealth level, area of residence, and income level of country on acute respiratory infections among young children. The analysis showed that ARI is expected to be 81% higher in children belonging to energy poor families then the family is having energy excess. Regarding wealth level of family, children belonging to poor families have 30% more chances of being attacked by ARI than middle and rich income families. Rural area children have 10% more probability of developing ARI than urban area. Children of low income countries have 50% more chance of having ARI than lower middle income countries. The findings greatly contribute to establishing a remarkable policy for achieving sustainable development goals regarding good health and clean energy in young children of low and lower middle income countries by using extended multidimensional energy poverty index. The outcomes of this study contributed significant addition regarding multidimensional energy poverty index, risk factors of ARI in young children using a large data set to establish a policy for ensuring sustainable energy services to improve children health, contributing to SDG 3 and 7. We are extremely grateful to multiple indicator cluster survey program developed by the United Nations Children's Fund, UNICEF, for providing us this data to conduct our study. And these are some useful references. Thank you so much for your attention and patience. Any questions? Thank you so much.
Thank you very much, Madam Maryam. It was a really great presentation. You have used so many different countries and different ways to present. Very nice. Questions and answers will be at the end of the presentation from all the presenters. So we have to wait. You finished your presentation 8 minutes before. So let's see if any attendees have any questions. You can post those in the Q&A section. Madam Maryam, you can close your presentation. We can go for another, go to another presenter now.
Okay, thank you so much.
While attendees are posting their questions in the Q&A section, now I would like to call upon our third presenter. The third presentation is on coverage and inequality trends on ownership and usage of mosquito nets in 34 sub-Saharan African countries. And now I invite Tingkai Zhang from Tsinghua University for the presentation. Floor is yours. Zhang,
okay, thank you. So let me share my screen. Can you see the PowerPoint?
Yeah.
Okay, and now it's full screen, right?
Perfect. Yeah. Okay, if you want,
thanks.
you can move the Teams.Microsoft. Yeah.
It's okay, right?
Yeah. Okay.
Okay.
Over to you.
Yes, thanks. So I will start my presentation. So first of all, I'd like to thank you the mix the mix team from UNICEF and as well as Bristol University to hold such kind of a conference for all the researchers and all the people who use mix to do their researches and exploration from all over the world. So I'm Tingkai Zhang. From Tsinghua University. I'm now a Master of Public Health student from the Vanke School of Public Health in Tsinghua University. And there are my colleagues, Shijiao Zhang, Shushu Wang, Maximilian Harnoth, so Richardson, and Zhicheng Wang. So we are all the authors for this work I'm gonna share with you. So our research entitled with and inequality trends on ownership and usage of mosquito nets in 34 sub-Saharan African countries. So I will start the presentation. So first of all, it's the introduction section. So our research is about malaria and mosquito nests, obviously. In general, in 2022, there were an estimated 249 million cases of malaria worldwide, with the largest numbers, which is around 94% malaria cases occurring in sub-Saharan Africa. And the use of mosquito nets has been recognized as one of the most cost-effective methods for preventing malaria transmissions. And actually, over the past 2 decades, global health initiatives such as organizations and donors have made so many investments in the distribution of mosquito nets. Um, but the equitable distribution and sustained use of mosquito nets remain challenging. And actually, there is an inequality in the net ownership and usage. And actually, there are so many reasons because, like, for example, there are significant inequalities in net ownership and usage persist, particularly in low income and rural households, which may increase their malaria risk. And there are also many other reasons, such as logistic issues, limited follow-up, and net replacement needs hinder long-term usage. So all of based on so many different reasons, actually there do exist a inequality in the net ownership and usage. That's why we want to explore more in our research. Here's the research gap. So previous research has primarily concentrated on the immediate outcomes of mosquito net distribution, such as initial coverage rates and reduction in malaria incidence. So there is a gap in understanding the long-term trend in mosquito net coverage, particularly in how inequalities in ownership and usage have evolved, like changed over time. And existing studies have not thoroughly explored the specific challenges, including challenges in obtaining, using, adhering, and replacing all all the mosquito nets. So faced by vulnerable demographic groups such as children under 5 and pregnant women, their needs to use the mosquito nets and the inequality in the usage of mosquito nets among these vulnerable groups also need to be researched. So the objectives of our research is first to describe the latest trends of mosquito nets coverage in these countries, and second, to study the inequality in the ownership and usage of mosquito nets at different wealth groups. So basically, we mainly focus on the inequalities among different wealth groups among the different countries. And second, as the third is to analyze the usage of mosquito nets among children under 5 and pregnant women, because children under 5 and pregnant women are the most vulnerable groups, and of course, it's also like the target group we want to focus on and pay more of attention and invest more to reach the sustainable development goals. Last but not least, we want to we want to explore the relationship between wealth inequalities and coverage and the usage of mosquito nets. Yes, so that's the objectives of our research. Now let's go to the method part. So first I will introduce the database we use in our research. Basically, we use databases from DHS and MIX from 2010 to 2023 because we want to, as much as we can, to include more latest databases. So we combine those two databases to get the data we want. So for each country, we include 2 rounds from DHS and mix. There are some criteria we can be seen as here. So the databases that cover the longest period possible with at least 4-year intervals between 2 surveys will be included. And databases with consistent service. So like if we use DHS for the first survey, we will try to use DHS in the second survey. Or it's the same for mix. So that's the 2 criteria for the database that we have included in the research. So in general, there were 34 sub-Saharan countries have been included in the surveys, which means there are 68 databases we have used. And we used 48 surveys from DHS and 20 surveys from Mix. The at the at the right side is the map of countries included in the study. Basically, we tried our best to include as much countries as we can. But first, there have to be surveyed on the malaria related questions, because there are some countries, let's say like South Africa or Lesotho, they just don't conquered the problem of malaria already. So there's no question about malaria in the surveys. Okay, so this table just showed only showed the mix the surveys from mix we have used in our research. So there are basically 20 surveys from mix we have included in this research. And then about the participants, our study tried to examine not only on the household level, but as well as the pregnant women and children level. So in general, for this 34 countries, we include such amount of households, pregnant women and children from children under 5 in our research. So here's the numbers of different levels. And for the health indicators, we used on the household level is the household ownership of mosquito nets. And for the women and children level, we examined the participants slept under mosquito nets before the survey, the last night before the survey. So here is the health indicator and the question where we get the health indicator. And also we want to examine inequality measures. So actually we adopt two measures to measure inequality. The first is the slope index of inequality, which can quantify the absolute difference. And relative index of inequality, which can measure the ratio of a health indicator between the most and the least advantaged group, which reflecting the relative inequality. However, because for every country, the time interval between the 2 rounds are different. So actually, if we want to compare the inequality trend between different countries, we need to have estimate the annual change, which can be compared. So finally, after we estimated the index of inequality, actually we also estimate the annual change rate of SII and RII. So finally, here is some statistical analysis, including the scatter diagram, linear regression, absolute change. In general, we want to present the trend and change between coverage change and inequality change through the past decade. So I will put more time on the results part because there are many results actually. So let's see the first figure. The first figure is the mean coverage levels by Wells quintile in the first and second surveys. And the mean coverage actually is a weighted coverage for all the countries. So actually, if we, for example, if we see the red line is represents the household possession of mosquito nets in the two surveys. So this one is for the survey 1, and this one is for the survey 2. We can see that actually in the past decades, the average level of household possession of mosquito nets increased, but the poorest and second poorest group actually the mean coverage increased like larger than the richest group, and likewise for the children and the pregnant women, kind of similar trend existed, but for the children and pregnant women, the richest group, the usage of among the richest group still rised in the past decade. And the second table is the annual change rate of coverage and usage of mosquito net. You can have a glance of the annual change rate here for those three different levels. In general, in the three different levels, the annual change rate of the coverage are all increasing, which means in the past decade, the usage and the possession of mosquito net increased in the three different levels generally. And we can also have a general glance of the inequality trend in the past decade in those countries. In general, you can see that the inequality decreased in the past decade, as well as the annual change rate, because the annual change rate for SII and RI it's all minus, which means the annual change rate in general decreased in the past decade. However, it can vary from countries, which we will examine more in the future and upcoming analyses. Okay, so here is the scatter diagram of annual change rate in RII and SII for household, pregnant women, and children. In general, actually here we take annual change rate of SI as the X-ray and X-axis, and the annual change rate of RII as the Y-axis. So we can compare or like to see the correlation, the relationship between the change of absolute inequality and the change of uh, relative inequality. Actually, overall changes in relative and absolute inequalities are positively correlated, which means they are all decreasing in general. But if one is increasing, the other one also increased. And the same trend can be found both in the household level, pregnant women in the women level, and as well as in the children level. But here is some exception, like Ghana, like in some countries, for example, Ghana, the changes in absolute and relative inequalities are inconsistent. Actually, it means some countries have a different pattern, maybe due to different patterns of distribution of the mosquito nets or other specific reasons, which we could explore more in the discussion part. Finally, we also examine the relationship between the annual change rate of inequality measures and coverage. In general, we can see that the increase in coverage and usage is positively correlated with the decrease in both absolute and relative inequalities, which means if in general, the whole coverage increased, the inequalities will decrease, which is also an example, like a proof of the effectiveness of the distribution programs we have been implemented. Last but not least, here is a diagram. It's a figure that we can say for the household, women and children. Actually, the countries in this analysis has been categorized into four groups based on the country's annual coverage change. And then we try to estimate the change between the two surveys, which might be complicated, but actually we can see that there is different pattern for household, women and children. And we can be seeing more actually. If we take women, for example, there are inequalities among the poorest group to the richest group, because you can say, like, as for example, for the decreasing group, if the general coverage of women's usage of mosquito decreased, actually the poorest group decreased the most, but actually the richest group did not really get affected by the general coverage decreasing. Uh, in contrast, the richest group, the usage in the richest group even increased in the last decades. So it's also another proof that there truly inequalities existed. And it's also very interesting that the pattern for household level are different from the patterns for women and children level, which means there's a gap between the ownership and the usage for the mosquito nets. Due to the time limitation, I will be fast in the discussion part. So the main findings is in this region, mosquito nets coverage and usage have generally increased across all the income groups. So the richest household has shown less improvement in bed net possession. And both absolute and relative inequalities have decreased between the two surveys, with improvements in coverage and usage correlating with this reduction. And the increase in coverage and usage is linked to a decrease in equalities, and changes in household mosquito net ownership show less inequalities due to high baseline coverage. In contrast, usage trends among women and children still reveal inequalities among wealth group, which with the poorest group being more affected when usage drops and the richest benefiting more from increases. And there are some implications and recommendations. Basically, public health programs should consider more frequent and targeted distribution efforts in high-risk areas and groups, obviously, but integrating mosquito net distribution with other health services and using mobile technology, if possible, to track and encourage usage might help address the gaps in coverage. So basically, that's the research we have done. Actually, there are some limitations for our research, but due to the time limitation, I won't share more here. So thank you very much again for your attention and for the holding of such conference. Thank you.
Thank you very much, Tingkai, for a very insightful presentation one more time. Please close your screen so that we can start our Q&A session. Now I request Bo, the co-chair, to moderate this question and answer session. Over to you.
Sure. Hello, everyone. I am afraid that I have not seen any questions coming into to the Q&A, so I kindly urge you to submit your questions there. However, there are some questions that Deepak has put, so maybe since you have microphone access, Deepak, maybe you can read your questions yourself. Over to you, Deepak.
No, thank you very much, Bo. I wanted other attendees also to write to motivate them, but I didn't see any questions from them. So I have 3 questions from each presenter for my understanding and better clarity. Let me start with Mr. Murendo. My question is that the concentration index which I observed in your presentation is 0.04. Basically, I understand that it is relatively low of inequality because it's very close to 0, and 0 stands for no inequality. So my question here is that what do you see in the ground situation in Afghanistan? Is it still relatively low, or it is very different? That's one question. You can come back. And the second question which I have for Madam Maryam and Sidra, what is the value of multidimensional energy poverty index, which you mentioned, which you calculated? Your remaining presentations is excellent. Just wanted to understand what is the magnitude of that energy poverty to understand the deprivation in the countries what you have presented. And the last question is for Mr. Tingkai. You actually gone through with a very detailed metadata analysis. My question is that when I see the participants, household, women and children, I wanted to understand whether they are weighted numbers or unweighted numbers. That's one. And the second question which I have, actually the period is to 2000, I think 10 onwards. I wanted to understand that did you or your team consider doing any correlation between the seasonality of data collection, means when the data was collected, and have a correlation with the ownership of mosquito net and usage. So because it has, because if we collect data in the month of summer, or if you collect data in the month of say winter or in rainy season, depending on the country specific, so mosquitoes availability is also varying from season. Is there anything coming? I just wanted to understand from that perspective. Over from my side. Over to Bo.
No, I think we can send it straight to answer. I see Maryam is raising her hand, so maybe we let Maryam answer the first questions that you had. Over to you, Maryam.
Hello, I'm Maryam. I want to answer your question. I'm again sharing the specific slide on which we have mentioned this index. Can you see this slide?
I think it's coming very slowly. There's a little bit of delay on the connection.
Can you see the slide, please?
Yes, the slide is there now.
Okay. You can see that we have given the weightings to the indicators, just like this fuel has the weight of 0.2 and indoor pollution is also weighted as 0.2. We have not calculated these indicators and multidimensional energy poverty index individually for each country, because this is not the dependent variable. This is used as independent variable. So we have just examined its influence on our ARI. But these are the weightings of each indicator of this index. Can you see each weighting?
We can see it's on the screen, yes.
Can you hear me?
Yes, we can hear you, but there is some delay on the connection.
Okay, this is the weight for electricity excess, indoor pollution, and we have used to calculate this index by using these weights for each indicator. And then we have examined the influence of this index on ARI. Basically, ARI is our dependent variable, and we are basically interested to observe the acute respiratory infection risk factors. So we have not calculated this index for each country, but hopefully we will include this in our article by calculating for each country as descriptive statistics. We will include this in our article.
So thank you very much, Maryam, for your answer. Actually, why I asked, because when I see this table, I see you have 5 dimensions and then you have the sub-dimensions. I was just thinking from the perspective of how you have weighted this dimension and sub-dimension, whether it's a self, but whatever, I mean, as you mentioned that you are going to do it when you are publishing paper, it is going to be very effective when you publish this one. Thank you very much.
Yeah, thank you so much.
Okay.
Hand over to Murendo. Yes, please go ahead.
Okay, thank you, Deepak, for that question. So ideally, what we are seeing on the ground is the health-seeking behavior is also quite low. From the ground situation, this can be explained by the 3 delays model, where we are seeing, because of lack of knowledge, at times women delaying decision-making to seek healthcare services. And when they do, at times the health facilities are also very far, poor road network infrastructure, where we were having also mobile health clinics. In the past, these are kind of shifting to static facilities following the authorities' decree. So basically, and again, where they reach the health facility, again, even if you might find the facilities are poor, lack of medication. So these all compounded together, they tend to result in a low health-seeking behavior. Following this, again, I'm going to disaggregate the data by urban versus rural so that we can also capture the spatial differences. Because it maybe hypothetically, we might want to see maybe there might be higher rates in urban areas compared to rural areas. But let's see when I work on the data set. But thank you for that. Yeah.
So thank you very much. Why I asked this question, largely because I was thinking that if the wealth quintile itself has a problem, because if all majorities are poor, then Q1, Q2, Q, so then your CI index calculation heavily depending on the accumulation of quintiles. So I don't see much change in Q1 and Q5. That's why I was asking. Thank you very much.
Yeah, I think added to that, I also maybe for robustness checks, we also need to look at whether there are additional variables that can be included in the wealth index. Yes, but thank you.
And then a good segment that you already asked a question to Tingkai, but another couple of questions arrived for him and his presentation. Maybe you can address Deepak's question first, Tingkai, and then have a look, or I can read them out loud for you. But let's hear what you say to Deepak. Over.
Okay, sure. So first, I also saw the upcoming questions, but first I'm gonna ask Deepak's questions. So first, the numbers I showed in the PowerPoint is unweighted because I want us to have a general glance of how large of the number. But actually, all the analysis we have done in the research were all weighted. If it's within the country, we weighted with the weight together with the database they provide, so there's a weight, right? And if it's in the region, we also combine the population in different years, which is a newly weighted how to say, so it's like we combine the population to have a new weight. Then we can have a general general glance of the how what is the result of the region, right? So that's my question for your first answer for your first question. And second, you asked if we consider the time of the survey collection, if it's in the rainy season or a dry season, because it can affect if the household have a mosquito net, even the usage, right? Actually, we do have a discussion when we do the result analysis, but actually we did not really reach to a agreement. So I think it's also a good opportunity to talk with like the data collection team, because we examine the time when the survey has been collected. Actually, it can verify for a short period of months. So sometimes it's not really in the rainy season or in the dry season. So we are not sure if we should consider it like two different participants, because in general, afterwards, it's a ecological results analysis. So actually we afterwards we base on the country level. And of course, at the same time, we also examined the previous studies. Some similar studies, they do not really consider the time of data collection. I assume that it's because they include so many countries, so they just maybe ignore the effect. So maybe I also want to hear from you, like, what's your suggestions? But I think it's really a important point for such kind of research. Yes, thanks.
You want to say more, Deepak, or maybe
No,
I can come in?
I wanted to say, but in the best interest of time, I don't want to say. But thank you very much for your clarity.
Yeah, Tingkai, while you look at the other questions, unfortunately, I am the focal point for malaria in mix. So I hear everything that you say about seasonality, and I agree that there are lots of studies out there that do not take seasonality into account, or the the timing of field work. From the operational side, I guess you can understand how complex a survey gets when you shift fieldwork timing to the high transmission period, because there are so many roads that get broken in countries that suffer from malaria. So it's really tricky. In some countries, I think sort of the gold standard on how to do this is to do part of the data collection outside the high transmission season. And then if you are collecting malaria testing, meaning what do you call it, parasitemia, etc., blood sampling, then you do a subsample of testing during high transmission season to get the closest to the most what should I say, reliable data. Anyway, just a few comments from my side. It's very tricky. It's incredibly costly to collect data during a high transmission because of logistics, basically. Anyway, over to you. You have several other questions.
Oh, yes, sure. So I saw the question from Alexandra. I will first answer that. Alexandra asked, because Alexandra asked why we only choose to use 2 surveys for each country, because there might be more surveys. Actually, there were definitely more surveys for each countries, especially for some countries that, like for Senegal, there are almost 10 surveys. You can find both in mix and DHS, because apparently Senegal was implemented, like every year there is some service implemented in Senegal. But the reason for us why we just choose two services is because we want to include as many countries as we can. Because if you look into the previous studies, there were some countries due to the lack of databases, there were some countries that have been barely examined. For example, like Congo, because uh, before the release of the new round of Congo, actually the latest the data set from Congo you can find is 2014 or like more or less. But fortunately, we have a new release of Congo. That's why we want to also like include such kind of country. But then it leads to a problem that for those countries, there are only 2 rounds maximum. But for some countries, there are super many rounds. So how can we like really how can we decide which round we can include or not? So finally, we set a timeline which is 2010, which is also the first like majority service have been like implemented for mix 4, right, around 2010. So another reason for this time is because the latest the latest trend study for mosquito nets can be found. It's like it's like around 2010, which means after 2010 there were limited such a big data studies for mosquito nets usage. That's why we set this time, and then we set 2 rounds because we want that each countries can be included under the same criteria. But then we try to maximize the time interval to keep it as a latest trend. Yes, that's my answer for Alexandra. And actually, Golda also asked the kind of similar question, because Golda asked what's the time interval, like the average time interval. Actually, I didn't mention it, but I showed in the PowerPoint. The average time interval is 9 years, which means it's relatively reliable because it's almost 10 years. So from 2010 to like plus 9 to 10 is 2020. Yeah, so that's a average time interval. And for Golda, another question is Golda asked the sleeping under a mosquito net is related to the night before the survey. It seems like these results can change in a very short time. For example, the mosquito net owner could have cleaned the net the day of the survey. Absolutely, I think, because actually many things can happen to affect the usage of the mosquito net before the last night before the survey. But in general, I think in this field, we all adopt such kind of measure because it's the easiest way that we can measure the usage of mosquito net. I think Bo should be a specialist in this area, right? Yeah, but based on what I understand, because I was also in Africa, so I know like how it can be tricky to use mosquito net, and actually, yeah, there can be many reasons could affect the usage of mosquito net. Yes. So that's my answers for the questions. I hope they're.
Yeah, thank you very much. I think we have exhausted our list of questions. Yeah. We still have about 15 minutes left of the session. So let me hand back to you, Deepak, to say a few words, and I can monitor if we get another question in. But to everyone participating, this is your last chance for questions. But thanks.
While other colleagues are thinking about what questions they need to ask, but I just wanted to say that all the 3 presentations are excellent. I mean, it brings diverse perspective, advancing the commitment of the presenters, also bringing the insightful contributions towards the health-seeking behavior. I think this kind of presentations are very helpful for us, and we actually get a lot of new ways of doing analysis. So thank you very much. I think it was great to have all the three presenters here, and also thanks to all the co-authors for contributing to the analysis.
We have one last comment from Sidra to Mr. Tingkai. Maybe a quick response from his side, and then we can close, Deepak.
Yeah.
Okay, sure. I just saw it.
Mm-hmm.
Oh, okay, sure. So Ms. Sidra wants to know the nature of the dependent variable. Actually, it can be a tricky question because, in general, there is no dependent variable in this research. So sorry. So I mean, so you ask in dependent variable. So sorry. So actually, the dependent variables are the health indicators, right? Because it's like the possession of the mosquito net and the usage of the mosquito net for pregnant women and children under 5, which means if they slept under the mosquito net in the last night before the survey or not. So basically, both of the variables are binary. They are either they have the mosquito net or they slept or they didn't. So it's binary. But in general, it's binary. Yes. The reason why I firstly did not really understand the question is because our research are more based on the trend and kind of description. So actually, we didn't really estimate the factors of all the independent variables to the health indicators. So that's why I didn't really get the point of the question first. Thanks.
That's all right. Okay, Deepak, from my side, let's call it a day.
Perfect. Then on behalf of the organizers, both chair and co-chair wanted to thank all the presenters, as well as gratitude to the attendees for their time and participation. Thank you very much. Let's close.
Thank you.